I'm Tony Leeds. I chair the TDMR Europe organisation, and it's my great pleasure to welcome you to this web seminar in which we're going to look at the role of total diet replacement in achieving an initial weight loss in a number of conditions, and then the issues that relate to achieving longer term weight maintenance. There are 4 of us participating today, but the main presentations will be from Neris Asbury from the University of Oxford, from Jenny Brand-Miller from the University of Sydney in Australia, and Michael Lean from the University of Glasgow. Total diet replacement offers an additional option to deliver amounts of weight loss between the values that are usually gained by conventional diet, perhaps up to 5 kilograms or a little higher in some cases, and then the amounts of weight loss that are achieved with bariatric surgery, where we see much greater weight losses. The rates of weight loss are fast, and it's important to note that this can be quite motivating. Individuals who've lost 1 or 2 kilograms after 10 or 2 weeks are really then quite strongly motivated to continue. They can be delivered in specialist primary care and community settings. There's experimental evidence in all of those settings. Compliance tends to be high. Safety profile is good. All of the adverse events are fully described in the publications. And for the examples that I've referred to, weight loss in knee osteoarthritis greatly reduces pain, and that pain reduction is actually maintained, provided weight reduction is also maintained. And in obstructive sleep apnea, there's a big improvement on the sleep state and also an improvement in quality of life. Neris and Mike will a little later on discuss the evidence in relation to reduction of medication costs, and also calculations have now been done on the cost effectiveness of this type of program.
And so now I want to sum up what we concluded from the previous study. First, we achieved a remarkable reduction in type 2 diabetes incidence. If we compare it to what we expected, it's a 75% reduction in risk. What are the reasons for such a low incidence? First, these are we think are the possibilities. First, we think it was the large initial weight loss, twice that was achieved in the Finnish diabetes prevention study. We think it was the fact that they were able, many of them, 1 in 2, were being able to sustain that weight loss of at least 5% for the duration of the 3 years. We think some of it is because they increased their protein intake. Both groups increased their protein intake and reduced their carbohydrate intake. So both of those factors might be operating. And lastly, we think it is the lower glycemic index and lower glycemic load, which may facilitate larger reductions in fat mass and HbA1c.
A referral to a commercial diet replacement program was feasible, acceptable, safe, clinically and cost-effective treatment for obesity in routine primary care. The weight losses averaged approximately 10 kilos at 1 year, and 45% of patients lost 10% or more of their baseline weight. And at 3 years, weight losses averaged approximately 7 kilos, and 23% of participants lost approximately 10% or more of their baseline weight. There were significant improvements in biomarkers of cardiovascular disease risk and diabetes at 1 year, and other trials that I'm sure Mike will talk about suggest that patients taken off all their diabetes medication, 45% of patients with type 2 diabetes can cease their medication. However, at 3 years, only blood pressure remains significantly different than at baseline, and we need to look into this further, but it is probably due to the weight regain profiles that we see. The cost per quality adjusted life year is less than £20,000 threshold, usually considered cost effective by the NHS, and the programme becomes more cost effective in higher risk groups.
We must treat type 2 diabetes and obesity, the disease process, much more seriously than we have in the past. Type 2 diabetes is at least as serious as some major cancers, and we need to treat the treatment as seriously as we would chemotherapy. We have an optimal diet program in terms of Counterweight Plus, which is well evaluated. We have the principles which can be applied elsewhere and evaluated. And we should, I think, be targeting 15 kilograms weight loss in Europeans, certainly, with the aim of getting the maximum number past the 10 kilogram cutoff. In Asians, it's possible because they start at a lower weight and have different body build, that we may be able to get by with 10 kilogram weight loss. We have a pilot study looking at that at the moment. But the big issue is long-term weight loss maintenance. I'm sure that's where our discussions will take us.
Yeah, I think the other important thing is there's no evidence that TDR disproportionately lose lean tissue. It's just, as Mike said, it's what happens when you lose weight.